Thanks, Gordon. What I'd now like to do is open up the discussion if people want to ask questions to the panelists. If I could remind you to say who you are, that's helpful for the panelists. Here in the middle, yeah? Richard?
Hi, I'm Richard Gregory from DFID. Thank you. It was really interesting from all the panelists. I have a question across the panel. That Gordon's point at the end there was that those in public service are maybe inclined to overreact to threats. Sometimes we also see as an incentive to underreport a threat and to cover things up and not react as quickly. And perhaps we could say that we've seen that in health crises in particular with some of the experiences in different countries of, say, cholera, or even in the early stages of the Ebola outbreak. I was just wondering if colleagues could maybe reflect on those two different incentives to sometimes underreport and sometimes overreact.
Who'd like to start on that one?
Okay. Thanks, Richie. I mean, I think the colleague just talked about, but that it's a tricky thing to do. Like, I mean, for example, in our case, is sometimes the incentive to underreport. For example, I mean, there was a lot of chatters in Monrovia when the last case was amplified. Should it have been? Could it have been managed? Because the truth is that in these kinds of situations, there are incentives and there are sanctions. In our case, reporting that last case, which probably could have been managed rather than creating the panic, which then drives investors and other people away. It is a real tricky ground, and it has to be managed in terms of how you report. It's a single case. You've gone 42 days, and you were declared Ebola free, and then several days later, another case pop up. Could it have been managed differently rather than create the international pandemonium? This is a real. I mean, I don't know the right answer, but I believe the experts in the area of health can advise in terms of how to manage it. But as a layman, I would think it has to be managed properly rather than creating too much. It doesn't mean you don't deal with it. It's what you get out there in the public that then creates additional scare and frighten people away. In our case, I mean, airlines stopped coming. A lot of things happen. There's actually a serious consequence. And so, I mean, but I believe those in the area of health, why it is true that they can find a way to deal with the situation, I believe managing the information is important for stability.
Do you want to add? No.
Just as a small point, I think that in the main, there is a structural leaning towards underreaction for a number of reasons. I think the first one being that we don't have strong monitoring and surveillance traditions. And most of these crises tend to emanate at some little rural place somewhere, whether it's cholera, whether it's typhoid, whether I can't speak about Ebola because we didn't have Ebola, but the pandemics that certainly we have gone through. So there's a tendency to underreact because people actually don't understand what is happening. If it's tuberculosis, even HIV/AIDS, people actually don't understand what is happening in the communities. Then when the government comes in now, the government has got a tendency as well to hide the facts, because that tends to reflect on them badly, either from a position of view of investors and political considerations. Governments tend to hide a lot of things, and we know from our experience with the way that in the majority African governments dealt with HIV/AIDS, including easily the most advanced economy on the African continent, South Africa. The issue, there was denialism for many, many years, yet thousands of people were dying. So there's actually a structural tendency towards under-response, again, because of a weakness in capacity. Also weakness in civic society. If we had a strong civic society, as we now do in many societies, some of the practices that used to happen in the past, they wouldn't. In these days, because of social media, the citizen is empowered. Every citizen has got a voice now on Twitter, on Facebook, and every citizen is a journalist. A camera can do fantastic things. But 4 or 5 years ago, that was not the case. So the tendency generally has been that of structural, underreaction.
I'd like to just add a quick observation. I was reading the very interesting article by Milan and the colleague there yesterday about the government's incentives to pursue curative action versus preventive actions. And their paper basically says there is a greater incentives for government to pursue curative actions because it's more visible, while preventive measures are not. We know that. That is true almost everywhere. However, that behavior could be changed or even altered theoretically and practically in China, where the central government said, look, if you serve as a local commander, let's say in a province, as a governor, okay? If we link the pandemic or massive crisis probability occurred in your province to your political promotion, if anything happened, no matter how you deal with it, someone will have to pay the price. And then we find these local authorities overreact to that policy change because they don't want their provinces to have such a massive crisis, no matter how they deal with it, because someone will have to pay the price. Of course, this policy change could alter their behavior, but you don't want to overuse such an incentive intervention because, as I said, in our recent explosion in Tianjin, in the first week or so, many local officers don't want to come up to lead the solution work for the crisis, because no one wants to become that target to pay the price, to pay the political price. Okay, so that is the problem of the over utilization of the incentives. So I think I just want to share that with you. This is not from the theory, this is from the truly experiment in a big country like China. You can change government behavior using that kind of policy design, but don't overuse it. So we got to be very careful in designing public policy interventions. Okay.
I'll go to Juan and then Eduardo.
Juan Costain from the World Bank. This is a question, I think, for the three ministers. That I think from what we heard yesterday, the message came across that at least for low-income countries, when we talk about government budgeting and systems, it's going to be largely on the preventative side rather than on the response side. And so when I've heard people discussing preparedness, I've heard basically three different scenarios given. One is that, particularly focusing on Ebola, that we had this crisis because the countries are really, across the board, not in a good situation, and what we need is a new Marshall Plan for Africa, and that's associated with people like Hans Rosling. Another group of people seem to be communicating an idea that said this is about health issues, and so what we need is a substantive investment in health systems across the countries. And then there seemed to be like a third group who said, well, no, pandemics are not really about health systems, they're about public health. And so what we really need, the money is scarce, and so what we really need is a more minimalist approach, looking particularly at the pandemic response issues in terms of surveillance, testing, and containment. And I'd like to hear from the ministers whether they think that's a correct assessment of the debate, are there other approaches, or what they think of those three different approaches.
Victor, do you want to start on this one?
Thanks, Yuan. I think that's a very interesting question. what I'll say to it is that you will find different responses because different countries are at different levels, and then what Liberia would do would be different from what we would do, would be different from what Zimbabwe would do, because we're different. We never had a case of Ebola. But I think the bottom line is that if you look at the three-pronged response that I talked about, we had public education, which is actually social mobilization, which goes beyond health. We had surveillance, which falls within the public health domain. And then we had case management, which falls within the institutional health setting. So if you have a case and your treatment is not robust, then no matter how much surveillance, contact tracing you do, so it's a continuum. And I think what I would like to stress is that you cannot strengthen one part without strengthening the others. Secondly, you cannot do it overnight. It's a continuous investment, and the responsibility lies largely with the country and the government, and all the help is welcome, but the countries have to be in the lead. It's eventually their responsibility. Thank you.
Okay, I mean, I think it's an important observation. But what I would like to underscore is that it has to be approached from a systems theory. So while it is true in our case it was a health crisis, there are a number of other systems that were affected, and so the approach in dealing with this situation has to be holistic. It was a health crisis. It had severe economic consequences. I mean, we're at the point, for example, in our case, where at one point in time, Ivory Coast and Nigeria had asked Maersk Line, the shipping company, that if you went to the port of Monrovia, you cannot come to our countries. Now, imagine you're fighting a health crisis, and then you go out of food, essential supplies. Imagine what that would mean. So, I mean, even though it was a health crisis, but because the country is not self-sufficient in food production and depend largely on imports, that was going to be another problem. Now, like in our case, and that's where we work with the international community and with development partners to help us approach this. So whether it's a Marshall Plan, and like Victor said, it would be on a case-by-case basis because each country is at a different level. In our case, even if we wanted to prepare, we do not have the fiscal space. Take, for example, Ghana. They said they're spending about $1.1 billion on health. That's 2 times our annual budget. We're around $550 to $600 million, per year. That's 2 times. What they just spend in health is 2 times what we spend overall. How much prepared can we be within that fiscal space? We don't have the fiscal space to, even if we wanted to. I mean, based on the crisis last year, we took a knee-jerk reaction, so we put some money down for disaster relief, $1 million. What can that do if there was a flood somewhere? It can do nothing. And so that's where international community will have to come and help us build these systems. At the same time, help us to expand our economy so that more people can participate in the economy is diversified. So I would say it has to be a system approach rather than taking a part of a system, because you can try to fix that part. Once you've not fixed the other surrounding systems, I think you'll be, throwing good money at something that you're not going to get the result.
Tendo, did you want to add something?
Yes, I think it's an interesting question. I think that the classification of the issues on the 3 legs you have done, they're not mutually exclusive. I think that what is fundamental is that we have to build sustainable states on the African continent. So the balance sheet right now is that you've got states that are uneven and unequal. So if you go to South Africa, for instance, you go to Johannesburg, you go to Cape Town, it's as good as being in any part of the developed world. But even in Johannesburg, 7 minutes from Sandton is a shanty town called Alex Park, which is a slum in capital letters. But that slum is the normal in the majority. That Alex Park is the normal in the majority of African cities across the continent. It's the Kibera that you will find in Nairobi, for instance. It's the Mbare that you will find in Harare. It's the Mandevu that you will find in Zambia, for instance. And then you've got this enclave economy, enclave status quo of a rural area. If you take Zimbabwe, for instance, only 30% of the citizens has got access to electricity. 58% of the citizen is still using the bush as ablution. Less than 60% of the population live in houses that are not covered by grass. So quite clearly, there must be an articulation of a developmental model that makes Africa be like, I don't think it would be funny if we were all like Joburg and Cape Town, but somewhere close to in terms of upliftment of people, in terms of our per capita incomes. And if you look at African story and the Asian, for instance, there's a huge contrast. When Ghana became independent in 1958, the Ghana economy at the same size as South Korea. But if you compare the two right now, there's absolutely no comparison. Zimbabwe had far much better statistics in 1980 when it became independent than Singapore when Singapore became independent in 1965. So how do you build, gap this huge deficit? Does it require a Marshall Plan? I think it's more than the resources alone. I think it's more than the resources alone. But certainly we need a plan. And if you doubt what I'm saying, you need to go to places like the Central African Republic, my own country, Zimbabwe, many other countries, Sudan, South Sudan, Somalia, Eritrea, and others that I shall not mention out of politeness. So we need definitely some developmental model. And then, of course, there are the manifestations of this crisis pandemic. Different countries differ. Ghana, by our standards, is a very developed African country, together with Nigeria, together with Kenya, for instance. The response that you're going to have from Ghana is materially different from the response you're going to have from Lesotho. Very different, because they're two different countries on the same African continent. So, which is why I say that the three issues are not mutually exclusive. But what I do know is that we are a long way from creating a sustainable Africa. And in the majority of African countries, I was speaking to a colleague yesterday that there are states in permanent crisis, whether it's Rwanda, whether it's Democratic Republic of Congo, whether it's Congo. So you are in permanent crisis, interrupted by a period of peace. But it's the natural DNA, the natural default setting is permanent crisis. Then you have peace 5 years, 10 years, then it comes again. How do you build sustainable Africa? And I guess the answer lies in development, democratization, rule of law, strong institutions, strong civic society.
Thank you. Eduardo, and then I'll go to Jennifer and Aaron.
Thank you, Peter. I really enjoy this panel. In middle-income countries, it's very difficult to see Ministry of Finance officials and Ministry of Health officials sharing the same table and talking about health. So I think middle-income countries have a lot to learn from low-income countries instead of how to build a good relationship. Now, in preparing for a pandemic, I think it's very important preparing a good relationship between the two ministries. Because the flow of funds, usually the initial recipient is the Ministries of Finance, and then the funds flow to the Ministries of Health as the execution agencies. And from what I've seen in many other countries, the Ministries of Finance see the Ministries of Health as a different entity, very difficult to understand what they do. And they're mostly seen as budgetary risks. There's a lot of distrust going on between the two ministries. So my question to the panel is, how do you prepare for a pandemic by building a good relationship between the two ministries and getting things going based on trust? So by the time they have to sit in the same cabinet, they have to work together, you eventually get things and decisions flowing very fast.
Oh, well, which goes first, the Ministry of Health or the Ministry of Finance?
I think maybe as a general observation, based on your experience, that may be true. In our case, that isn't particularly the case because maybe, and this is unique, maybe because most of us today who work in the Ministry of Finance came from the Ministry of Planning. So we do have a better appreciation of strategic planning and the key sectors in the economy. For example, before I came to the position in 2009, I worked as the person coordinating the implementation of our poverty reduction strategy. So I did have the opportunity to work with all of the actors and build a relationship with them, and knew that within our system, coordination was a major problem. And that was the reason why, as a whole of government, we're not achieving most of what we set up in the poverty reduction one. And so we come with that understanding, to the extent that during the health crisis, the Minister of Finance, myself, and our core team moved into the Ministry of Health to work with them. So it was not just, we did first try to create what we call the Ebola Trust Fund. We moved quickly, because at that time our budget had not been approved. We moved quickly working with the central bank and with the national legislature to get emergency spending authority, and work with the central bank to get the initial $5 million to put there as seed money that we'll be using to respond to the crisis. Why international support came. We did that around the end of July, beginning of August. That wasn't sufficient. We had to move in the Ministry of Health to work with them, think strategically about how to address this. So money is available, but what is it that you're going to do with the money? To do that kind of strategic thinking and planning, because we just thought that throwing money around and sending soldiers around and police around and manning the border would not cut it. You have to sit down and think strategically in terms of what you're going to do. So we have a very good working relation. I mean, even now we're working with our Ministry of Health. What happened in our situation is that when we have all of these pooled funds and other financing instruments, most of the health workers move with these funds. They're on the fund's payroll, and when these funds are shutting down or they're leaving, we have a huge pool of health workers who are not on the government payroll. So we're working with the Ministry of Health and say, look, you know, our partners will take care of other things, maybe providing medicine and supplies and equipment, but let it be the government responsibility to take on the health workers. So we don't have a crisis with health workers not being on the payroll. So we're working. So we've worked very good with our Ministry of Health because we do understand the challenges. And maybe it's because we come from a planning background. We've been all along working with them in terms of creating the strategic plan for health. We worked with them when we're implementing the basic package of health services and move on to the essential package of health services. So we have a deeper understanding and therefore appreciation of what needs to happen. So that may not be, our case may be unique, but that is not particularly true because we've been able to work with them very, very closely in achieving some of the goals so far.
Victor?
Yes, just 2 or 3. Eduardo, I think that's a fascinating question. First of all, I want to say that in Ghana, the Ministry of Health has been a victim of its own success. I talked about the swap, which meant that we were getting a lot of resources from development partners directly, which made us, like the orphan of the Ministry of Finance, get along, go and do your own business. I mean, last week, my former boss, Mark Dybel, was in Accra signing a $300 million grant over the next 3 years for malaria, TB, and HIV. So massive resources coming directly from development partners. Second thing is that in Ghana, at least, a lot of money is being given to the Ministry of Health by the Ministry of Finance, and it's increased exponentially. The Ministry of Finance thinks that sometimes we're not very efficient with the use of those resources. So there's that ongoing discussion about why the National Health Insurance Authority is given more money because there's, as you know, 2.5% of all the value-added tax goes to the health insurance. And yet we have evidence that some of the system is gamed, people take advantage of it. So the discussion with the Ministry of Finance is how can you then use this money more efficiently before you come for more? Because we're a country in crisis, we need money for energy, and it's $1 million a kilowatt. You know, they're rolling blackouts in Accra and so on. Why should we continue to give you more when the Ministry of Health, and specifically the National Health Insurance Authority, is given more money than any ministry, department, or agency? So the dialogue is good, but we've just learned that the response from the Ministry of Finance is always no before they even listen to the next level. But I must admit that sometimes it is for good reason, because there are many efficiencies that we can gain with what has already been given to us.
Yes, I think that the Westminster model of government, which the former English colonies follow, Ghana, Kenya, Zimbabwe, Malawi, Zambia, and so forth, makes the Minister of Finance the Chancellor of the Exchequer a very powerful individual, which is good if there is a understanding in that government of a common vision and a common priority that, look, health is our priority, or education, the social services, and so forth. I think the situation disconnects where, if there is weak leadership, particularly the head of state, and in the case of Zimbabwe, you've had that challenge that the center doesn't hold. And in my own experience when I was in government, I sometimes felt that the power that I had was just too, criminally irresponsible. It was too much power on one individual, the discretion that, that I had as an individual. Sometimes just to say, guys, this is what I'm going to do with the budget. I'm going to allocate Y. Some my colleagues would find it, you're wasting their time. You're actually disturbing them. So there was this silo approach to governance. The Minister of Finance is a silo there. The Minister of Education is a silo there. The Minister of Health is a silo there. So I think that's a unique Zimbabwean situation. What I can speak in general terms is that for countries that are doing well, particularly the middle income countries, Ghana, Nigeria, Kenya, to a very large extent, Mozambique, Uganda, they are, because of various protocols at the Mozambique, Kampala, Ethiopia, at these protocols, we are supposed to allocate a certain amount to health, like 15% and so forth. So many countries that is being done. And Ghana is a good example. Kenya is a good example. Uganda is a good example. The challenge comes to fragile states, weak budgets. So you find this problem in a place like Zimbabwe, for instance. James was just mentioning the challenges of a weak budget. That is where you then find a situation where social issues, health and education and social grants, become soft targets against the bigger competing interests of roads, dams, and sometimes peace and stability. Just giving monies to program of integration of the armies, securing the borders becomes a higher priority than social budgets. So you find that in fragile states, the social budget suffers because of the higher competing interests of national security, peace, stability, and so forth. And it takes a pandemic like Ebola for the whole government to then say, oh, health is important. But everything being equal, in fragile states, social issues suffer.
I think that's a very, very important question. But there's no good answer. The short answer is, again, institutional policy setting as best way to solve it. I'm a big fan of the insurance policy under clearly defined hard budget, as opposed to administrative intervention by government under soft budget. Before 2009, Chinese healthcare system is basically a supply side approach system by allocating resources from public finance to Ministry of Health directly through supply side. And then your concern about trust between the two ministries was dominant, which is true, because it's almost impossible for Ministry of Finance to audit every single item that was spent by Ministry of Health entities. In 2009, the State Council concluded that something must be done to change the way resources are allocated on supply side to demand side through insurance policy setting. So now we have three entities to deal with the problem. Ministry of Finance to cut the check to the Ministry of Health. But Ministry of Health will not directly get a check on supply side. It will go through Ministry of Social Security and Human Resources, which now has insurance policy settings to allocate the resources. So basically now the money will follow each individual's that is being covered in the insurance policy. So now there's not much mistrust between Ministry of Finance and Ministry of Health because the money goes to insurance policy settings. So of course the Ministry of Social Security and Human Resources will have big challenge to conduct work for payment reform. How do you pay the providers, right? Faithful service, capitation, or by disease or DRG type payment. So it is a big task for the third party, insurance party, to allocate the resources through demand side approach. That's what's been done in China.
Jennifer.
Thank you. Jennifer Adams from USAID. And I wanted to ask Gordon Yu a question about something that I experienced in China after the 2008 earthquake. So the Wenchuan earthquake was huge, and it was in a very rural, sort of isolated and poor part of China. And in the rebuilding effort after that in Wenchuan, there was a kind of a unique example where there was a policy put in place where Jiangsu province had to spend, I think it was something like 1 or 1.5% of its annual budget for 1 or 2 years in Wenchuan. And there was also a provision where many technical experts from Shanghai and Jiangsu province had to report for duty and actually live and work in Wenchuan for quite long periods of time. You ran into them all the time. All these people from Shanghai were living in Wenchuan and working on the rebuilding and on the capacity building effort. So I just wondered what the thinking was, now that it's been several years, about that model, about that experience. I mean, maybe China's the only place that you could do that, but I wondered if it would be something that you would recommend to other countries.
Well, I think this question goes all the way back to my first point that I shared with you. It's a fundamental economic question. You're absolutely right. In the case of China, when earthquake occurred in Wenchuan County, my hometown, the central government basically played a very drastic, big role in mobilizing resources nationally. As you said correctly, central government basically asked each province governor or major city mayor to determine which part of the county or which county in Sichuan province that was affected by the earthquake. Your city, your province is designated to contribute to the rebuild and development of the county influenced by the earthquake. It becomes a political task. No one dare not to follow it. So almost every county, every township that was affected by the earthquake in Sichuan province was helped with the direct contribution by the provinces and cities in other places. Now looking back, yes, when you go to Wenchuan County these days, if you guys will visit China, many townships and county facilities are so well developed because of the huge support directly from each province and each city, okay? Is this the right approach to do? I am not sure, because again, this is the outcome of political decision. We have many other demands, as we said earlier, that need resources. Why just Wenchuan now? Because that's a political spot, all right? So that's why I alert everybody here that when we're talking about the preparation for pandemic threat to a society, usually that could become a political issue in a country like China, so the resources could be overutilized. In the case of China, I'm not sure if that could happen in other countries. So as an economist, I would always be cautious about such a, what I call an overreaction if you have resources available.
Erin.
Hi, Erin Holfelder from the One Campaign. Thanks for this panel. It's been very helpfully grounding, I think, some of the more theoretical discussions from yesterday, so really appreciate the perspective. My question is primarily for James. I'm curious to hear from your perspective, particularly at the sort of peak of the crisis in Liberia when perhaps the most external resources were flowing through your country, to what extent you and your colleagues felt like you had oversight and accountability into those external funds, and if that oversight was limited, to what extent that impeded or impacted your own planning for how to spend your own government's resources.
Okay, thank you. The blunt answer is never. We never had oversight. It was a problem. I think even when the Guinean president visited our president, he raised that issue. I know in the Paris Declaration we talk about mutual accountability, and it's easier for donors to come and say government systems are weak and place transparency and accountability burden on recipient country government, but then never do the same. They never do. They never report to anybody. And so we hear and record these hundreds of millions of dollars that are coming to the country. How they will use, we never know. We're still waiting. What we decided to use an approach is that since we set up our Ebola Trust Fund, we said we will lead by example. And so what we will do is that we do a proper accounting and publication of reports of our funds, and then we demand from partners. Let them show the hundreds of millions of dollars they receive, how were those resources expended. But we will do ours on our $25 million we have in our Ebola Trust Fund. Every 3 months, we will publish a report. We ask our General Auditing Commission to actually do an audit. That report was published, and we're hoping that donors will follow suit on that mutual accountability, that you ask us to account, that you too should take the moral high ground and do the accounting. But yes, how the resources came, how they were spent, we don't know. I know there was one point in time when I had an exchange with one of the partners. At a certain point in the crisis, at the beginning of the crisis, it made sense because we needed ambulances to be able to pick up sick people and dead bodies from the street. So they were taking single cabin pickups and converting them to ambulances. That was okay. But at a certain time in the crisis, when we're turning the corner, I'm saying you have to buy now rear ambulances so that we're able to use them after the crisis ended. And then some guy will say that's the only thing Liberia will get. We'll continue to buy pickups and turn them into ambulances. I say that's unfair. These are public resources given to you. You cannot use your personal feeling to expend those resources. We believe that gone are the days when we're using pickups and ambulances. We have to start thinking. That's why I say these relief financing have to be strategic. At a certain part of the crisis, you need to start thinking beyond the crisis. What happens? What's wrong with sending for ambulances? Ambulances are available in the country. Why don't you buy rear ambulances that have all of the equipment and facility in it, so that even after the crisis, they can be used? Why are we still turning pickups into ambulances? But yes, we never had control. Maybe one day we will.
I know there's lots of questions, but I'm afraid we're going to run out of time. I think we have time for one more, and I think Martin was the next in line, and then I think we're going to have to close.
So I've really enjoyed this panel because what we've really been saying here is that some of the best insurance is not putting it into some sort of insurance fund or premiums to be unlocked at the time of an event for response. The best insurance is to build capacity so that the best way to respond to the next pandemic or big epidemic is to use systems already running. Because if you try to build at the time of a pandemic, you'll always be behind the 8 ball. You'll always be delivering after the peak has come. And this is good. And indeed, Liberia should have better roads, and there should be more energy capacity built and generation capacity built in Africa throughout every country. But I also know it's true for the US, Peter, for the UK. If we have an influenza pandemic that's like 1957 or even 1968, even in the US, there will be, for certain supplies and services, demand will exceed what can rationally be delivered. Supply will not meet demand for certain services and supplies. A case in point is just mechanical ventilators in this country. We will not be able to deliver enough mechanical ventilators at peak. So here's the question to the panel members, anyone so brave. What can we do as part of the preparation to deal with, no matter how hard we work and how much money is put out, there will still be gaps. We can't buy our way out of every part of the problem. How do governments deal with now, planning and preparing as part of that, with dealing with the unmet demand and variety of issues? Some of it you will only find out at the time of the pandemic or the epidemic. What can we do to improve that gap? Response to that gap.
A nice, easy question to close the discussion with. Who wants to put their head up? Or, okay, Victor.
Martin, fascinating question. I think what we are doing in Ghana, even though we didn't have Ebola, is to start with the planning. Because I think the bedrock of everything is anticipation and planning. And I think we've heard from our colleagues that these things, it's not a question of whether, it's a question of when. But then when you have, there's some known knowns, some things that doesn't matter whether it's cholera, Ebola, whatever, there's some things that you can put in place. Once you have the plan, the work plan, the budget, you can build on that. So what we are doing right now in Ghana, for example, is we're moving from that one disease to an integrated plan that everybody can buy into. And then from there, we'll build up depending on what the specific event is.
Let me try to answer your tough question. I think in dealing with unmet demand for health needs in a pandemic event, maybe a PPP or private-public partnership model can be a good option, where you let the insurance-based policy run by private parties to serve as the essential supply of the goods and funds to meet the primary part of the demand. And then there is unmet demand, which can be served or better served or more effectively served by government buffer. So don't use the government buffer to serve as the fundamental part, but let the policy-guided insurance setting to serve the primary part, and have a government reserves to pay for the unmet demands for the care. I think that will be, in my view, practically feasible and perhaps economically more beneficial than otherwise.
I think we've had a very rich discussion. I'd like to ask you to join me in thanking our 4 panelists. Thank you very much.